Hi there. So today's day number 2 of the American Occupational Health Conference, and I'd like to report on 3 sessions that I attended today. The first one was an update in neurology pertaining to occupational and environmental medicine. This update was provided by Dr. Aohc from the University of California at San Francisco. And basically it was a kind of a list of a lot of neurological conditions that may be work-related or may have an impact on fitness for work. So I'm not going to review all of the very large number of conditions mentioned in this presentation, just a couple of those. Plexopathies. This is something that I have to say it's something that I don't see that often in my practice. So Dr. Aohc was mentioning the upper trunk plexopathy happening when you have injuries, when you push your arm like this and you have your head in the opposite direction. So you would have issues with the upper side of the plexus with the C5 and C6 roots. So you may have the muscle defects, muscle weakness related to this in either the deltoid, biceps, and so forth. You may also have, and it's a little bit more rare, lower trunk plexopathies when you pull up your arm. So in this case, you would have rather the C8 or T1 root that may be injured, and accordingly the muscles innerved with those roots. There was a bunch of other conditions. Is mentioned, of course, traumatic brain injury. A thing that I didn't know was some new stuff. I say new because obviously I'm not a neurologist, so it may be not that new, but for me it was something new. A new series of medications for the treatment of migraine called DTANs, which are targeting the serotonin 1F receptors. And the interest of this is that it may be useful for people having cardiovascular histories. In such case, we cannot use triptans. So it's something that can be interesting, although it's not that much work related, but we may see patients having those medications in our practice. Is mentioned sleep apnea, and functional neurological disorders that may happen. So meaning situations in which the patient has some symptoms that cannot be explained with any brain defect, any objective finding is associated to it. So it may be a little bit of a challenge when we see those patients. And he's finished his presentation with a little bit of neurotoxicology, mentioning movement disorders with N-propyl bromide that can be used as a degreaser, and a bunch of other stuff. It was pretty much an overview and a bit quick, but an opportunity to see the vast range of possible conditions in neurology. Second presentation today, a fantastic presentation on Toxnet. What happened to Toxnet? An update on web resources for the occupational health professional. And here we had a presentation with several speakers on health informatics first. So what is public health informatics, with Richard Hamel, who gave some definitions as to what clinical informatics is. And it was mentioning the fact that first, competences in clinical informatics are considered now core requirements for any physicians. And it was citing someone saying that the search engine is now as essential as the stethoscope, which is kind of true now. He's provided some reminders on the Boolean operators, like when you do a research strategy, you are going to use likely and or not. which may help you have a refined research strategy. He's mentioned the variety of databases we may scroll. He's made the distinction between bibliographic content, such as databases such as Medline, or catalogs such as the Aohc catalog. Second, the full text contents that may contain electronic publications or digital books, mentioning the NCBI bookshelf or StatPearls. The third one would be annotated content that includes database management systems such as the Cochrane collaboration, or a website called HasMap, and I'm gonna talk a little bit more on that later on. And final, the aggregated content with Toxnet, ATSDR, and Medline Plus, etc. Then, second part of the presentation, what happened to Toxnet? So, Toxnet was a website that was under the bigger structure of NLM, and NIH, basically on toxicology. But the thing is that NLM has gone through a restructuring and a strategic plan, which include like withdrawal of Toxnet. So we shouldn't worry too much, because the content of whatever was in Toxnet has been pretty much redistributed to other databases. So it's more now an issue of where we do access the information. So basically, to say it quite simply, our first way to go as occupational medicine specialists would be now PubChem. And in PubChem, you would have a lot of information there, toxicology data, links to other databases, and so forth. So it was kind of useful to have this presentation, to have like a kind of an overview of the databases we may use. And I realized that going with PubMed as a first option when I do a literature review for a patient I see in clinics may not be the most efficient way. And I'm going to revise my practice and probably move to PubChem to improve the quality of my research. The speaker has also mentioned a bunch of other databases, such as LactMed, for instance, anything related to toxicity and human breastfeeding issues. A comparative toxicogenomic database called CTD, a household products database, not yet in PubChem. But this household products database is interesting because there's a lot of products, 23,000 products used in both the US and Canada that are listed there, and it may be a good place to search for safety data sheets. An interesting e-learning module would be a Tox Tutor. This is still developed under the NCBI NLM collaboration. And it's a series of e-learning module. I've scrolled this quite quickly. It's a 3-hour time commitment, if I understand well. And it provides kind of an overview of foundations in toxicity. So now moving on to HasMap. So HasMap, HAZMAP, for Hazard Map, is a relational database of occupational toxicology. It has been developed by one of the speakers, actually, and his name was, and I'm scrolling again, Jay Brown, so the developer of HasMap, and it was explaining that back in the days, and I believe it's been created in 1985, if I'm not wrong. I don't remember where I put this in my notes, but yeah, I guess it's something like this. And it's been developed under the software Access. And this reminded me that a lot of software used in the medical field were developed back in the days by passionate physicians using Access as a way to develop innovative software, and pretty much easy at that time. So basically it links exposures to occupational diseases and job tasks, industries, etc. It's a very good website, but I would say it may be more useful for those with I would say limited expertise in occupational medicine and toxicology. So for non-specialists, I would say it's a great resource. It's a great resource to get started, to see where you can find some of the exposures, etc. So that's a great resource to have. So that's pretty much it with this second session. And the third one I'd like to report was also a really interesting session that I followed afterwards, because the sessions are recorded and some are early in the morning my time, or some are scheduled at the same time. So we have the opportunity to look again at some sessions. So this is what I did this afternoon. And this last session was on Beryllium and BeLPT, so Beryllium lymphocyte proliferation test. So this was quite a comprehensive and very interesting overview of what we would need to know about beryllium. So in a nutshell, beryllium, where do you find it? Mostly in aerospace industry. You can also find this in nuclear industry, in telescopes. Very interesting metal, very strong, very light, like a very solid metal that can be used with copper to make alloys. Copper and beryllium together, it would increase the melting point, it will increase the thermal conductivity, and it will reduce the corrosion. Some regulatory aspects, the exposure limits decided by Aohc have been updated in 2017, and basically it has been reduced from 90% of the previous standards, so moving from 2 micrograms per cubic meter to 0.2 micrograms per cubic meter for an 8-hour time weight of average. Action level is half of that, so 0.1 microgram per cubic meter. Clinical surveillance must include respiratory, including PFT, dermatological exam, and BeLPT repeated every 2 years. That's easier said than done, because in our country, in Canada, access to BeLPT is very, very difficult. It's same in the US. Very few labs are actually running those tests on a regular basis. And as I'm going to explain in a second, it's a very technical test, very, very challenging. So in terms of clinics, beryllium is responsible for a bunch of conditions. First, sensitization. So when your test is positive, the BeLPT is positive, it's called beryllium sensitization, BES. When you have BES plus clinical symptoms or features of granulomas, when you have clinical evidence of an impairment, then it becomes a disease called chronic beryllium disease, CBD. Not to forget that beryllium is also responsible for lung cancer. It's IROC1. And back in the days, it was responsible for acute beryllium disease. Pretty much rare now, because the levels of exposure are now way lower than it was back in the days. There are susceptibility genes that have been rediscovered for providing an increased risk of beryllium disease among certain people exposed. Positivity of the BeLPT may occur within 9 weeks of the first exposure. Basically, it's impossible to distinguish CBD from sarcoidosis. The symptoms are the same, imaging are pretty much the same. You can have either ground glass opacities, nodular findings, or fibrosis. So moving on to the test itself. So basically you would need 30 cc of blood. You're going to do a centrifugation of this blood. It's going to separate. You would have a layer of white blood cells. You're going to take it, wash it, count it, and you're going to put those cells into on a 96 well culture plate, and you would add some beryllium to each of these well with different range of concentration, and you would do an incubation for both 5 and 7 days for 2 incubation of several concentration for each patient. So you already understand that for one single blood sample, you're going to run a bunch of different analyses. You would have different measurements to do. So when it's incubated, you put this out of your incubator, you add some tritiated thymidine, so it's going to incorporate to the DNA. You wait for 6 more hours, and then you freeze your proliferation, and then you're going to count your radioactivity. And depending on the level of radioactivity, because the tritiated thymidine is radioactive, of course, so the more you have radioactivity, the more proliferation you would have. So then you have the results. So if you have no excess proliferation, so meaning you don't have any more proliferation depending on the exposure of the cell to beryllium, you would have a normal test. The abnormal test would be in 2 of your wells. You would have a greater than normal proliferation. And then you have all of the in between, 1 well, and then you need to repeat the test. So to finish this with this presentation, this test is very much complicated. There is a number of other options that have been or that are explored, such as technologies that are pretty much similar to the IGRA tools we use for TB diagnosis. So far, none of this tool has been validated for chronic beryllium disease. So I'm done with today. I realize my videos are pretty much long, so sorry for that. I try to be a little bit more short tomorrow. And have a nice day.